if it works. Can you see my
yeah, it's going. Yeah.
Okay.
Yes, Ferran.
Okay, perfect. Thank you very much for inviting me. As Dr. Soldado said, I'm Ferran Blasco. I'm working in the trauma unit in Barcelona, Hospital Vall d'Hebron, and this is part of my PhD. So the problem here is that pediatric forearm fractures can lead to malunion in up to 15% of cases. And the first question we can ask ourselves is, what is the clinically acceptable threshold for angular deformity in forearm fractures? In the current literature, has been shown that over 10 to 20 degrees of the diaphyseal malunion can lead to a significant loss of forearm rotation. The standard of care for this situation are nowadays corrective osteotomies. Here we present our case, which is a 13-year-old male who fell over outstretched arm and suffered a both bone forearm fracture. It was treated conservatively with a closure reduction and casting, and as we can see in the lateral X-ray, correction of deformity was achieved. But after 3 months, the patient suffered another trauma in the upper limb and sustained a both bones forearm fracture. As you can see in the X-ray, there is an angular deformity of 20 degrees in extension in midshaft of the radius. After closure reduction and casting, 12 degrees of extension deformity persisted in the midshaft of the radius. This patient, after 2.5 years, came to the clinics because he was suffering a symptomatic forearm rotation deficit. As you can see in the video, we have a full supination, but only about 10 degrees of pronation. So what are the treatment options in this situation? And to know the options, we need to know which is the main cause for the rotational deficit of the forearm. Is bone deformity, or it may be the interosseous membrane scarring. That's why we performed our study with the objective to investigate the role of interosseous membrane in the rotational deficit after midshaft radius extension deformity. We hypothesized that interosseous membrane release improved forearm rotation. And the methods were an in vitro biomechanical study to evaluate and compare the forearm rotation with intact interosseous membrane and after releasing the interosseous membrane in midshaft radius extension malunion model. Here we can see a picture of our model. We can see the radius already with the deformity, fixed with a prevent plate. We can see the interosseous membrane already released and the rotational reference system with key wires in the distal radius and ulna. Here we show our results. We used 10 specimens per group. We designed 2 groups, 10 and 20 degrees midshaft radius extension deformity. We can see that the rotation in the intact forearm was around 160 degrees. The rotation after the deformity was decreased significantly, and interestingly, we found that really the interosseous membrane release we got a significant increase in forearm rotation. As we can see, much more in the 20 degrees midshaft radius extension deformity. In terms of discussion for the in vitro part of the study, we found that intact forearm rotation and the decrease in the forearm rotation following the bone angulation that we got was similar to previously reported studies. No previous interosseous membrane release in forearm malunion cadaver model has been reported nowadays. There is only one single clinical study performed by Nagy et al. In 2008, in which they were treating malunited forearm fractures. They first got the corrective osteotomies, and afterwards, if the rotation of the forearm was not enough, they were performing the interosseous membrane release. And they didn't find any complications in terms of pain, synostosis, or instability of the distal radioulnar joint. So we are back in our case. We remember the important forearm rotation deficit pre-operatively, and we performed an isolated interosseous membrane release through a volar approach. Here we can see the vast increase in the pronation and the stability of the distal radioulnar joint. Here we can see that we increased the rotation from 10 degrees of pronation to 90 degrees of pronation. Here we can see the small incision we did for this operation, and those are the clinical pictures after more than 2 years after the procedure. As we can see, the supination is full supination, and pronation, there was a small limitation, 60 degrees of pronation. We didn't find any weakness, instability, synostosis, or pain in the distal radioulnar joint. And here we show the X-rays, where we can see that there is no synostosis, and the deformity of the bone is present. Here we show our small case series, where we can see that the preoperative pronation in all cases with extension deformity of the radius was 0 or 10 degrees, and how it increased after the interosseous membrane release. There was a case, a really severe case, where we performed the osteotomy and then the interosseous membrane release, and was the one who got the worst results in the follow-up. In terms of discussion, isolated interosseous membrane release without the need for bone osteotomy and plate fixation may be enough to obtain a functional forearm rotation in selected cases. Interosseous membrane release with intact bony anatomy would not result in any axial or forearm instability as far as bony structures are present. There is a logical concern about the progressive development of distal radioulnar joint instability due to the increase of tension in those ligaments. Here, we present a proposed algorithm for those cases. These malunited forearm fractures, we have to check the distal radioulnar joint. If this is stable, you can perform safely the isolated interosseous membrane release. If the distal radioulnar joint is unstable, you may go first for the corrective osteotomy, so the orientation of the distal radius and ulna is corrected, and then if the rotation is not enough, you may go for the interosseous membrane release. So in conclusion, the interosseous membrane release could have a role in the therapeutic arsenal for the treatment of malunion and extension of mid-shaft radius fractures. We are ongoing additional studies to simulate other malunion patterns. We are almost done with the mid-shaft radius flexion malunion, and we found, as preliminary results, that isolated interosseous membrane release doesn't increase forearm rotation. And we are starting the cadaveric model for proximal third radius malunion. Thank you very much.
Wonderful, Ferran. Wonderful. Thank you.
Thank you.
Ferran, one question. In those three cases with mid-shaft extension radius malunion, which was the angulation?
In those clinical cases? So the one we presented here, it was not that much deformity. It was just like about 12 degrees, but they are all over 10 degrees. But there is one of those cases got a couple of operations and reoperations due to non-union before. So the scarring of the interosseous membrane may be the main problem in those cases. They are all kind of end stage forearm fractures with a lot of rigidity. They are not kind of straightforward cases. They are all
because there must be a number after which the interosseous membrane has no sense, no? Because imagine 30 degrees, no, of the diaphysis, of angulation of the diaphysis, but all of them were like the less than 20, right?
Yes.
Less than 20. Okay. Any comment from
even if you go for 30 degrees, for example, I think it would make sense to first address the bony part and then see if you get enough forearm rotation. And if there is not enough forearm rotation after the osteotomies, you may think about releasing the interosseous membrane.
Ferran, in the cadaver, we choose 10 and 20, right? Yes. And why not 30? I don't remember, because there was like a bony impeachment, no? Was it or not?
Yes, because if you go for a more severe deformity, I think it doesn't make sense to go as for the isolated interosseous membrane release. I think it may be as an adjunct treatment, the interosseous membrane release. Yeah. I don't think it makes sense because the distal joint, I don't think it will work with this degree of deformity.
Okay, comments from the board or from the from every participant, please. Message. Why it's called? Yeah. There is a very good question. So it should be a supination. Sorry. It's a question for you. What is it called? Extension malunion.
So because in the cadaveric model, we went for we made a model for the extension deformity, also for the flexion. We are ongoing for the flexion deformity. So it's important because you have to make sure that you have to understand the deformity of the bone before going for this treatment. You need to know if it's an extension or flexion. There is also one of the limitations of this in vitro study is that we didn't simulate any angular deformity, any rotational deformity, which is also a problem of those fractures. So this is the first step of a kind of a large way of thinking about the forearm malunion treatment. This is not the end of the study. You know what I mean? ¿Cuánta longitud de membrana se libera? So to make it simple and easy to reproducible, we did we released the whole membrane. We only left the distal radial joint and the proximal. We go for the whole interosseous membrane. That's a reasonable question, and it could make sense in the future, depending on the location of the deformity. Maybe you don't need to go for the whole interosseous membrane release.
Ferran, one question, Ferran. Is there any model which tells you how much bone supination you have depending on how much extension you have?
In fact, I understood that I know that extension deformity is normally because of a supination moment when you have the trauma. So when you are reducing the fracture with a closed technique, you have to reduce it in pronation normally. But I didn't find any model that was showing it in any in vitro study or clinical. I didn't find it, but that's what makes what I always understood from forearm fractures.
Okay, Scott, Dan, are you aware or any study doing this correlation between extension and supination in supination deformities in the forearm supination malunion?
I'm unaware. Paco, I'm still struggling with the concept. I know I asked the question about extension. Extension means what? We would say that's an apex volar malunion.
Yeah. It would be apex volar, yes.
Okay.
So you say apex volar malunion, Scott?
That's how we define it. We don't define it as extension.
It's common in the literature to find it as volar or dorsal apex deformity, yes. But we called it extension.
And Paco, we certainly see the same thing, and I know we're talking about today in BP or sometimes in CP, where the forearm gets stuck in supination, and you release the membrane and you gain pronation. But that's a different entity than what you guys are talking about. What's interesting to me is it's a acute phenomenon. I've always wondered whether the interosseous membrane is scarred over time, or does it just happen? If you're in your model, it's acute.
Acute.
Yeah,
Right.
Interesting.
I mean, the model, in fact, is tensioned more than scarred because it's cadaveric. So there is, in the model, there is no scar. There is just tension more than scarring. Scarring, it would be what we understand that happens in the patients. But the model is the tension that got with the deformity, I would say.
Yes, you, Scott, Dan Slotolov, in one of his papers, hypothesized that over time you can have a scar, so you have to correct the deformity before 1 year or 6 months, right? So you were thinking also about the interosseous membrane role in the malunion, right?
For sure, actually, for sure. But that's what's so fascinating about this is an acute phenomenon. I mean, there's also an interesting question about, we know that the interosseous membrane gets tight in supination. So how does increasing or releasing the membrane give you increased pronation? That's the question.
I would say that when I was thinking about the discussion, I searched a lot of papers about when is the interosseous membrane more tension, and I found that not only in supination, some papers were saying that was in neutral or also in pronation. So I don't think this is as established as it would sound here in the question. That would be my.
Let me make Dan a co-host. He's asking me to, because okay, co-host.
I think I'm unmuted.
You can unmute
already.
you.
Yeah.
Dan, you can unmute you.
No, I'm good. Can you hear me?
Okay.
Yeah. So the comment that I had made before is based on a Tar, I think it's Tar, Garfinkel, and Sarmiento, and they did osteotomies. Yeah, I'm sure you know this paper.
Yeah, sure. This is we yes.
Yeah, so they and there's another study where they look at Montesias, and after a year, I don't think it's the same group. There's another study where they looked at Montesias, and after a year, corrective osteotomies did not really help. But I think one thing we've discovered, I think, is through using computer modeled osteotomies, is that I think that's not true. I think the reason that you have a year to fix these fractures by eye is because after a year, you can't tell what the deformity is because of remodeling. But I think that I think this lends further evidence that maybe the IOM just stays as it is. And it's not the IOM that causes the problem long term. It's just this sort of bony remodeling that really changes things and makes it more difficult. Because we've done corrective osteotomies now years out and have had no issues with forearm rotation. That's not true. We've had some residual forearm rotation loss, but we've certainly not had any issues restoring DRUJ or PRUJ stability. As long as you get the bone, more DRUJ stability if you restore the bony anatomy. PRUJ is still more difficult. You agree, Scott? Anything? Oh, you're muted.
Scott.
Okay, I'm unmuted. No, I totally agree. I think we've learned a lot from this 3D modeling about bony correction. That's what's so interesting to me, that there's an acute loss of rotation secondary to the bone. It's kind of all making sense if you think about it. But I agree with Dan 100%. After a year, especially in children, you can't tell where the bone was broken or the angular deformity or how much remodeling has occurred. And I think that's why we've always had the tenet that after a year you cannot gain rotation. But I don't think that's true anymore. I agree.
So Scott, in the flexion model, apex dorsal, IOM release doesn't increase the rotation. but in the proximal third of the radius, it release also increase the supination. We want to play with everything: radius, ulna, flexion, extension, rotation. So we will discover in the future.
Yeah, I mean, Paco, the measurements we talk about in terms of what's acceptable and what's not acceptable are poorly defined. And I think what you're trying to do is define those acceptable versus unacceptable. A lot of times, Dan and I will look at an X-ray and just go, that's not going to work. It needs to be reduced. But there's no absolute number that we rely upon other than the crossover sign. So if you look at the X-ray that's up there, that middle X-ray on the right, so there's 1, 2, 3, 4, the fifth X-ray from left to right, that the radius that crosses over the ulna there on that lateral X-ray, that's a problem.
Yeah, there are many factors like age, level, ulna, and radius, rotation that you are not able to evaluate. So many factors, yes.
Yeah, but I do think Scott's right that the crossover sign, regardless of age, has been very reliable. When I've taken those kids to the OR, they all have loss of form rotation, one way or the other.
Yeah. So when you say once they're asleep and you examine them, that crossover sign, that's Chad Price's crossover sign. It is reliable. They will not be able to rotate. And when you lessen or when you correct that crossover, they will gain rotation immediately.
So sorry, I didn't understand. Can you repeat the
Dan, you want to give it a go?
Yeah, sure. If you look at that X-ray that Scott pointed out, you can see how the radius goes up over the ulna and then back around. So it crosses over. And once it crosses over the ulna, and this happens really on proximal third radius fractures, this crossover. Once you get that, it's deceptively large amount of angulation. And we have found universally that when we take these kids to the OR, they have loss of rotation. And we've also been very happy with the outcomes so far and we usually plate these because they're hard to really hold with a rod.
Okay.
Yep.
Thank you. So should we move to the next talk? Oh, there are some comments here. So Praveen asked about the cutoff to decide to go. This is theoretical, but maybe 20, because in the cadaver at 30 there was like
impeachment,
bone impeachment, right?
I don't think it doesn't make sense to make isolated interosseous membrane release if the deformity is over 20 degrees. I don't think so.
Very good. Thank you, Scott, for sharing the reference. And then they asked how much, what length of the interosseous membrane do you release? You answered to that, right?
Yeah, I already answered, yes.
Okay, so let's go.
Sorry, it's missing one question about Campbell 1 that says the majority of the interosseous membrane is tight in supination. The release here sits.
Yes. I answered that. I don't think this is as certain as it was. It is written here because there is literature available that says that it's also in neutral position and also in slight pronation. I don't know what the panel says, but that's what what the literature says about the tension of the interosseous membrane.
Yes, I checked some specimens, and there are parts of the interosseous membrane that gets tied in supination and parts that get tied into pronation. So, which is what you are saying. Okay, can you stop sharing?
Yes.
Ferran?
Is it?
Yes. So I don't know if Professor El Gammal is here. Let me check. Gammal, participantes. Do you see Gammal? Can you see Gammal? I don't know now how to. Aquí, Gammal. Let's put aquí. Gammal. By the name, I don't find him. Tarek. No Tarek. TG, no TG. So let's go to the last talk and let's see if Professor Gammal. I will text Professor Gammal. So Praveen, do you mind to give your talk now?
Yeah, sure. That will be good.
Thank you, Praveen.
Pleasure. Is my screen seen over there?
Yes.
Okay, good. Yeah, good morning and good afternoon, everyone. I'll be talking about the wrist deformity correction in cerebral palsy. So we all are very familiar with this type of presentation, and all the cerebral palsy patients, maximum patients would actually present with deformity at the wrist. And that remains one of the common concern of the parents and also the patients. I think in India, one of the main reason why these patients present around the teenage is because that time they start thinking about their posture, and the paralyzed look what a person gets by the flexed wrist is the one which brings them very often. Yes, it does cause functional disabilities because when the wrist is flexed, the grip strength would be much less. And with a flexed wrist, the fingers have to work much harder to open up to pick up various objects. And we can see the patients often would have a good finger flexion, but the flexed wrist itself would make them look very disabled and also make them feel as if the function of the hand is not good. So when you are correcting a wrist deformity, you will have satisfaction of getting an improved function and also an improved appearance, which patients generally like. However, it is quite challenging, like any other operation in upper limb in cerebral palsy patients, because we know that tendon transfers by long have been the operation treatment for these patients. And these tendon transfers don't work as well as they work in trauma. So if there is somebody who is a trauma surgeon doing a lot of nerve surgeries, and then he progresses onto the spastic upper limb, they would be really very depressed seeing that the outcomes they are getting is not as what they were getting in trauma. That is because the tendons don't really follow the rules of tendon transfer, that they don't work in the correct force and they don't work in the correct phase. And many times you will not be able to find out what is the actual power of the muscle because of the spasticity. And these all lead to all the challenges in spastic upper limb. So the main important challenges what a surgeon dealing with this would face is the poor voluntary control, the spasticity of the muscle, which will make it difficult for one to understand whether the muscle is powerful or it is just because of spasticity it is feeling very tight. Often you will have weak donors. The assessment in these children could be very difficult. And at times as they grow, they may develop contractures which are difficult to correct. And of course, if more contracture is there, you will not be able to do tendon transfers. However, I think the most difficult challenge for a surgeon when dealing with cerebral palsy is the learned disuse. Because you would see that after our operations, many patients would get a good posture of the wrist. It will look as if it should function well, but it doesn't. When they come to the hospital, we see the child looking great. And if we ask him to pick up some objects, he's doing quite comfortably. But parents would say that he is not using the hand at all. So that is mainly because of the learned disuse. And maybe that is the reason when we analyzed our patients with FCU to ECRB, we found that there was a good satisfaction among the parents about the improvement in the posture, but they felt that there was no change in the function at all. And it can be all attributed to the learned disuse, which I think is the most difficult thing to correct in these children. However, in spite of all these negative things and challenges, the satisfaction with surgery in this patient is quite profound, because they improve in function. Even if they are not using it well, they become capable of using, and their appearance is improved, which dramatically improves their confidence and involvement in the societies. Hence, as a surgeon, hand surgeons, I think most of the times we are very aware that we do operations where the functional improvement could be expected. But in cerebral palsy, improvement in appearance also should be given a top priority. In young girls, if you just improve the function, their overall look towards the society and themselves improves a lot. And also improvement in hygiene could be considered as an indication for surgery. What is an ideal age for doing surgery? I think anytime after 6 years should be okay, because at around 6, the motor patterns usually get established. It is easy to assess the children, and they are able to cooperate well with our rehabilitation protocol. So, but older age is not a problem, because once the patients are older, though it appears like reconstruction could be difficult in an older patient, but we have observed that older patients are not that difficult, because they are more committed to rehab and they are more easy to assess. So if there are no contracture, they would get result just like a child. But we need to be very careful, because older patient would have got adjusted to some abnormal adjustment patterns, and by our surgery, we should not disturb them. If we take care of that, then it should be fine. The next question what surgeon has to think of is whether to correct all the deformities from the shoulder to thumb at one stage or in multiple stages. Yes, going stage by stage is sometimes safer, especially when you are in the early stages of spastic upper limb career. In them, you start proximally and then gradually move distally. But as you become more comfortable, I think doing all the level surgeries at one time is more effective, because you are able to achieve the final outcome much earlier. And also, we must understand that if we correct only the wrist deformity and don't correct the thumb in palm deformity, the patient is not going to use the hand. So the patient satisfaction, parental satisfaction would come only after all the stages of the surgeries are over. So that makes a good sense of correcting all the deformities at one time. Though more often we would be doing multiple level corrections at same time. But here today we are going to talk more about the wrist deformities. Now, when we go for correction of wrist deformities, we are quite aware about a lot of classifications which are available. But this is one scheme which we follow at our hospital, and we try to teach to all the fellows, because spastic upper limb can be quite intimidating to any person who is not seen it often, and they really get confused, like what you are deciding, why you are deciding. So these are the 5 steps we feel that will allow us to decide on various things what you want to decide in a spastic upper limb. Let us go to them one by one. So first thing we do is we check whether the patient has got finger flexion. So generally we ask him to hold our fingers and try to squeeze the fingers. So if the patient is able to flex the fingers and hold our fingers, that gives us a very good information that patient has got a voluntary control in the fingers. So if patient is not able to hold my fingers at all, I think that patient cannot be made functional. But if he is able to hold my fingers, we could think that this patient can be taken up for surgery. So this is the first information we want, whether this patient is suitable for doing an operation. The second thing we ask is we ask the patient to do finger extension. Irrespective of the position of the wrist, we ask him to just straighten the fingers. If patient is able to do finger extension in any position of the wrist, that indicates that some amount of finger extension power is present, and the spasticity of flexors is not too much. And these patients, after surgery, could be made so good that they can start using the hand more independently. But if the patient does not have any finger extension at all, suppose the hand remains like this, fully flexed, you could still do an operation, you could improve the grasp, but this patient will not achieve an independent hand function because finger opening is must for anybody to go and grasp any object. So this examination allows us to gauge the level of improvement what we are expecting in this patient and what we can offer to the parents. The third thing is to check whether wrist extension is possible with fingers flexed. So if the wrist extension is possible with fingers flexed, that indicates that there is good amount of power in the wrist extensors, and we do not want any tendon transfer to augment the wrist extension. Whereas if with fingers flexed, the wrist extension is not possible, then we must have a tendon transfer to extend the wrist. So it gives about an information whether you will require a tendon transfer to improve the wrist extension or not. The fourth thing is, in the previous examination, we have checked wrist extension with fingers flexed. Now we ask for the patient to do a wrist extension with finger extended. A patient like this, who is able to extend the wrist with fingers flexed, but unable to extend the wrist with finger extended, this indicates that this patient has got sufficient power of the wrist extensors, but the long flexors are spastic. So such a patient could get better in wrist posture just by tackling the spasticity of the finger flexors. This level of tightness of the flexors can be judged by checking the Wogmack angle, and that will give us an idea whether you can do a fractional lengthening or you require more aggressive ways of lengthening or releasing the flexor tendons. The last thing we do is we stabilize the wrist and then ask the patient to extend the fingers. On stabilizing the wrist, if patient is able to get full extension, that means there is no spasticity of the long flexors. And this patient would not require any fractional lengthening of the long flexors. This is important to know. We should not do fractional lengthening for each and every case, because fractional lengthening does reduce the flexion power and also could result in swan neck deformity in many patients. So whenever it is required, we must do, yes. But when you stabilize the wrist and patient is able to do full finger extension, in those cases, you do not require to do a fractional lengthening. It's very uncommon, but it is the situation. So that is the first information we get by this test. The second information what we get is, if the patient was able to do wrist extension with finger flexed, that indicates that the patient has got very severe FCU overactivity. And if we do release or neurectomy of the FCU, we could get a good result. If the patient does not have finger extension actively, but passively you are able to extend, that would indicate that this patient would require augmentation of the finger extension. That is very uncommon, but it could be one of the reasons why the patient is adopting a flexed wrist posture just in order to improve their finger opening up. And by examining this, you should be able to come to that conclusion. So that's how, following all these steps, we can actually tell whether this patient is suitable for doing surgery, what could be our aim for surgical intervention in such a case, and what type of surgical intervention you would like to do for such a patient. Just putting the same 5 steps to this clinical case. Here, wrist extension not possible, even with finger flexed. So you need an augmentation of wrist extension, but good finger extension possible, and it is possible also with stabilized wrist. So that indicates that this patient only requires augmentation of the wrist extension and nothing required for the fingers. She undergoes an FCU to ECRB transfer without any fractional lengthening to get a good result. Whereas this example, a patient on stabilizing the wrist, not able to extend the fingers, that is because of the long flexor spasticity. And here we need to do a fractional lengthening of the fingers and also an FCU to ECRB transfer, and which we can expect to get a very decent functional outcome. Zancoli classification is the most commonly used and quite useful in categorizing and comparing the patient. However, we have just added an additional C category onto this, which you get to know while you are checking the finger extension with the wrist stabilized, and this will tell us whether there is an FC overactivity which will require to be addressed, or there is weakness of the finger extension which can be addressed by doing your tendon transfer to EDC rather than to the wrist extensors. Now, when you are talking about the surgeries in spastic upper limbs, it is basically you are trying to reduce the spasticity or tightness of the spastic muscles and to release the contractures. And you want to augment the weak extensors, which are generally the wrist extensors. The contracture or spasticity can be reduced by doing an aponeurosis release, fractional lengthening, flexor pronator slide, flexor tendon lengthening, FDS to FDP transfer, in this order. So the initial options give the minimum amount of lengthening and the later one gives the maximum amount of lengthening. You could also consider doing a bone shortening or wrist fusion, which also could be effective, but they are usually kept as reserve. The augmentation of wrist extension is generally, classically it has been done by FCU to ECRB transfer, the famous Green's transfer. But of late, the ECU to ECRB transfer is gradually becoming more popular, and we will discuss why so. And as I mentioned earlier, if we find that the patient has got weakness of finger extension, we must carefully look for that, and we could transfer our tendon to the EDC as well. The nerve surgery in cerebral palsies are becoming quite popular now. We have tried all these operations and found that the result for elbow is great. The elbow result is quite nice, but we are still not very getting good result for the fingers, and the tendon transfer still remain the main operations what we do. The commonest operation for reducing spasticity by far is the fractional lengthening, where you divide the tendinous part at the musculotendinous overlap area, and you could roughly get about 1.5 centimeter of lengthening, and also it reduces the spasticity. The augmentation of wrist extension, which is the commonest operation required, could be done by FCU to ECRB or ECU to ECRB. FCU to ECRB, everyone is more familiar, and it is a commonly done operation. We have found it to be quite effective, but we must be very careful because FCU to ECRB could result in overactivity of the ECU, resulting in hyperextension contracture as the child is growing. And many of the children may be just holding the wrist up in tenodesis and not able to flex the wrist at all. So when you are doing an FCU to ECRB transfer, we must make sure that the tension is not much. We must make sure that the FCU is not overspastic. Otherwise, it will result in this hyperextension deformity, which actually could be more disabling than the flexion deformity itself. And this has been reported in literature in this paper where there was a very high incidence of developing a wrist extension deformity. The ECU to ECRB transfer has been there for quite some time, but this article gives a very nice scientific proof and evidence for why the ECU could be a good transfer, because it was found that the ECU in most of these patients with flexion ulnar deviation deformity have a volar subluxation, and it starts acting like a flexor. And when it is acting like a flexor, it is a sort of deforming force, and removing that and putting on to the wrist could be actually a very logical solution. So what we do is, when we are operating any patient with spastic hand, we routinely expose the ECU and pull and see how it is moving the wrist. It's very surprising that most of the patient with anything more than mild deformity, the ECU would be causing flexion of the wrist rather than ulnar deviation or extension. And this kind of ECU is quite suitable ECU to ECRB transfer, and FCU spasticity can be tackled by doing a fractional lengthening. This is some of the results of ECU to ECRB transfer. It can be done in very younger patients. This preoperative photograph, patient having a dynamic flexion posture, the ECU taken from the ulnar side and transfer onto the ECRB, and this is the kind of postoperative result you can get. The good thing about this transfer is it doesn't result in that kind of fixed extension posture. And since the FCU is maintained, they retain good amount of flexion at the wrist, and wrist looks more dynamic and more functional after the transfer. So presently, actually, many of our patients would have more often doing an ECU to ECRB transfer than FCU to ECRB transfer. And it works quite well. But there are many situations in which you would not have a patient who is ideal for doing a tendon transfer. There is quite a hesitation among surgeons for doing a wrist fusion, and everyone would try to extend the indications for doing tendon transfer. But I think that is not correct, because wrist fusion is not that bad operation in this group of patients. In fact, if we have a patient who is anything more than 14 to 15 years of age with this much severe deformities, especially if the FCR is not functional, and we know if FCR is not functional and we take away FCU, they are more likely to get into the extension posture. And if their finger extension is not good, then we consider wrist orthodesis as a first option in these patients. And we have found that the results are quite good. So this patient who underwent a proximal row carpectomy and wrist fusion, proximal row carpectomy allowed that much of bone shortening so that the spasticity could be reduced. The FCU, which was the only functioning wrist flexor, was in the second stage transferred to the EDC to get an finger extension. And FCR, which was weak, but it was put as a tenodesis for the thumb. You can see there is a good posture of the wrist. The fingers are opening up. The thumb is opening up. And she is able to quite comfortably pick up things and use the hand for all activities. By seeing some good results of wrist fusion and tendon transfer, we are quite comfortable in offering this patient to these teenage patients, because it dramatically improves the posture of the upper limb and also the appearance of the patient as a whole. Such a severe deformity, immediately after the surgery, just in 2 months, you see the patient look more confident, and she also feels that she can do much better with her hand. It's a pre-operative video. We can see a severe deformity and patient really struggling to pick up anything. She was just having an extension possible in the index finger, and other fingers there was no extension possible. We treated her in 2 stages. In first stage, we did a wrist arthrodesis, and then the wrist flexors were done tendon transfer for the finger extension and for the thumb. And this is the posture and the function what she attained. This is just about 6 months from the operation. And we can, by her dress up itself, we can make out how confident she looks, and she feels that her life is much changed and she's able to use her hand much better. So in the beginning, I think it is safe to go by staged reconstruction, as was our practice some time back, but now we routinely do multi-level surgery at a single stage. And we have found that it is much effective, allows you to go to the functional status much early. For example, this patient who was 15 years, good motivated guy with wrist deformity, thumb in palm posture, elbow flexion deformity, which was more of a dynamic deformity. And we decided to do all the corrections at a single stage. And this is the outcome you can get. This is just at 6 months after the surgery. You can see the symmetry of his opening up the fingers, opening up the thumb, and the wrist is quite stable, and his elbow also is opened up quite well. And this can be achieved within 6 months. If you are going stage by stage, it will take many years to achieve to this level. When we analyzed 53 of our patients at 1 year follow-up, we found that all of them improved in their spontaneous functional analysis, dynamic posture, and grasp and release. The best thing is, which applies mainly to our center, because patients come from far away place, and this allows a single rehab where the patient can stay near to the hospital and undergo rehab under supervision. And that, I think, has made a lot of difference to the patient satisfaction and also our outcome. Interestingly, we didn't find any effect of the age on the final outcome. And as you would have seen, many of the patients which I have shown in my presentation with good results are all more than about 15 years of age. In conclusion, I think in spastic upper limbs, the most important thing is assessment and repeat assessment. These patients, the operation and the outcome, what you are going to get, is often decided by the type of operation you decide for them. Just to emphasize the importance of assessment, this patient who on first look looks like a wrist flexion deformity, and okay, we are going to require a tendon transfer for finger extension. But when we went through over those 5 steps of examining the wrist, we found that when you are stabilizing the wrist, he is not able to do any finger extension at all. And passively, the finger extension was possible. So he looks like he is able to extend the fingers, but when you stabilize the wrist, no finger extension, and passive extension was possible. So this indicates that this patient actually lacks extension power at the fingers, and once the FCU was transferred to the finger extensors, his wrist posture improved. He was able to open up the fingers well, and he started using the hand much more comfortably. So that is the importance of correctly examining the patient so that you can tailor to what the deformity requires. So having said that, often we would see patients who would, by normal rules of spastic upper limb, would appear that if they are not suitable for surgery, such a severe deformity, what function he is going to get? He is already 20 years and he may not be able to use hand at all. But I think talking to them well, under promising and involving the patient in their own care can take us a long way. This patient, we first told that we are going to just improve the posture by wrist fusion. And then we did tendon transfer for finger extension and thumb extension. And then we corrected his swan neck posture. And ultimately, we could reach to this stage where this patient was difficult to control. He would go to gym, lift up heavy objects, and we always worry about the wrist plate inside. But he would actually send a message that he is quite okay and we should not worry about him. So I think with good involvement of the patient in their treatment care, proper assessment and decision making, letting them know what we can expect from the operation goes a long way and can be life-changing for many patients. Thank you so much.
Thank you, Praveen. This is a really hard topic because there are that many factors that it's difficult, but let's try. First question, Praveen. How do you decide if you try to improve wrist extension or, let's say, hand function, if it's reconstructible or not? Is it based in max, house? How you decide to do surgery for the hand, not for wrist extension, for the hand or not?
Yeah. So if the patient is able to grasp the fingers, I think that patient is our indication for doing operation. That patient can undergo operation.
Okay, grasp finger. That's good.
Yeah. So that's very practical, and that means that voluntary control is there. Yes, we will have difference in the expectations what you can have depending on how the tendons are functioning, but that patient can undergo operation, and that patient could be made better in the appearance and in the function. Yes.
That's very nice. Anyone in the panel or anyone in the audience, when do you consider that functional surgery for the hand is contraindicated?
Praveen, I really I love the way you've put this together, and I think it's things that we've thought about, but not necessarily placed in such a specific schema. So I think kudos to you for doing that. And what's interesting is that we've sort of converged on, I mean, our experience has been very, very similar. Although I think we tend more towards flexor pronator slides than to wrist fusions. But I think, one of the things that you mentioned was the Volkmann's angle, right? And I think Volkmann's angle is so important. And one thing that we've been talking about for years, but didn't have a name for it, we started calling a active Volkmann's, which is what's the wrist position that you can bring it where you have full finger extension, right? And that's exactly what you're alluding to. And this is something that Scott taught me. And I think that that's something that for those of you who are listening or watching this, I think it's so important, finger extension in addition to finger flexion. And if you take somebody who has obligate wrist flexion for finger extension, and you don't do anything about their finger flexors, and you bring their wrist up, they're just going to get stuck right here, which is the things you were saying. I just love the way you put this together, and kudos to you. Really, that's all I have to say. I don't have any questions other than say that was great.
Thank you.
Anyone else in the audience regarding the question about when not to do surgery, not to do functional surgery in a spastic hand?
Well, if I can go on specifically with your question, Chesko. So, I think it depends on what your goals are, right? We still will operate on patients who have really who are stuck like this and really have no use of their hand. And what I found is sometimes when you do a flexor pronator slide, you'll actually get a little bit of finger flexion from those patients. But at least you can convert a hand that isn't usable to a hand that can be used as a paperweight. And that's kind of it's still moving up on the house classification a little bit, if they have some use of the hand versus not. So I think Praveen's point is really well taken. I don't think you're going to get function if their hand can open but can't close, right? So if they bring their wrist down and there's no functional, you're not going to get function. But nonetheless, from an appearance standpoint and from a just passive posture standpoint, I think you can still do a lot to help these patients. But again, you're not going to get function.
Okay, so let's go to another point. I don't do tendon transfers for finger extension because the few cases I tried, it didn't work. Like in osteobrachial plexus palsy, maybe because of the muscle retraction. So this is my idea that tendon transfer for wrist extension in CP do not work. So it surprised me. What other people in the group think does?
Yeah, I think in spastic upper limb, as you are telling, it is difficult for them to work, but they are indicated less often. And in birth palsy, they don't work. The finger extensor transfer does not work because many of the patients don't have any of the wrist flexors working. Since the wrist flexor is not working, whatever transfer you do, there is no volar stability at the wrist and the finger extension would not come. So we had a lot of problems with finger extension in birth palsy. But recently, when we understood this point, we try to restore wrist flexion as well. So suppose I am doing a tendon transfer for finger extension. Same time, there should be a transfer which stabilizes the wrist. If wrist is stabilized, then the finger extension transfer would work better.
Or the fusion, right?
See the common combination or the fusion. Because the common combination is patients would lack finger extension and wrist flexion. So if wrist flexion deficit is not addressed, the finger extension also would not come.
Interesting.
So that is about the birth palsy. In spastic upper limbs, I think as Zankoli very precisely is put in his book that most of the patients do not require tendon transfer for finger extension because he feels it is always because of the flexor spasticity, the fingers are not opening up. So that is the reason why very rarely, but there are some patients who would be lacking finger extension power. So if you stabilize the wrist and patient is not able to extend the fingers, but passively it is possible, that is a good indicator that he requires tendon transfer for finger extension. One other way to check is we can give a block to the median and ulnar nerve and check whether the finger extensors are present or not. And if finger extension is present after median and ulnar nerve block, that indicates that a fractional lengthening or release of the flexor is sufficient and we don't have to do any tendon transfer for finger extension. So these are the two things by which we decide whether we augment the finger extension or not. And maybe if I have to give a figure, out of every 10 patients whom we operate, out of 10, only one patient would require a transfer for finger extension. So it is much less commonly required. Yeah.
Nice. I'm enjoying a lot. Any comment regarding that in the audience?
Paco, just a comment. I think it's a basic problem with finger extension, right? It's that MCP joint extension is extrinsic and IP joint extension tends to be intrinsic. And it's hard to overcome that without one or the other. In other words, if you have intrinsic extension at your PIP joint, then it's easy to overcome MCP joint extension. But the lack of both, whether it be CP or BP or spinal cord injury, is just hard to overcome. And I think that you have to do some form of stabilization of the MCP joint to allow for the extrinsics to extend the IP joint. I mean, it's basic Paul Brand biomechanics, as Praveen mentioned. I think it's a finger extension without wrist flexion is very difficult to regain. Praveen, the other problem we've had is if once you mess with the FDS and you get the swan neck deformity, because they're trying to use their extrinsic finger extensors to extend the wrist, and if you get a swan neck, it can be a cat chasing the tail. It could be a hard problem to solve. So my question, do you preferentially lengthen the FDP and try and leave the FDS behind, or you just go for both and deal with the swan neck?
Yeah. I think we start with the FDP, but most often we don't get the finger deformity correction with FDP, and then we go for FDS also. But we try to be more protective to prevent any swan neck deformity. And if it develops, we correct it. Because unless the FDS is released, most of the patients will still continue to have the spasticity of the fingers.
And how do you correct what is your technique to correct the swan neck deformity? You prefer technique?
Yeah, I think after trying all the things, I think for us, the one which is working more reliably is the FDS stenodesis.
FDS stenodesis, okay.
Yeah.
Well, essentially, we've had the same. I've tried a lot the central slip tenotomy, and it's very unreliable. Even in the same hand, you'll get two fingers that work great and two fingers that just either can't. Usually, you just lose extension, and then you end up chasing your tail a little bit. So I think I'm starting to go in that direction as well. But I think also just to comment on the tendon transfers for finger extension, I think that this is where awake surgery can be really helpful. If you can determine, for example, that the FCR is volitionally activated, then it's really wonderful to be able to transfer that for finger extension. So I think there are multiple tendon transfers you can use for finger extension, including brachioradialis, and you just have to judge whether or not those things are moving actively. And I think that awake surgery can be very helpful. It doesn't have to be wide awake; they can be sedated, but it's very helpful. I don't know if you have experience with that, Praveen.
Yeah, we tried for some, of course, in small kids, we will not be able to do. But when we have done up in little bit grown patients, we found that it was quite good, especially if you are doing a flexor pronator slide. It actually gives a quite good gauge of how much to release and how much aggressive you should be while releasing. Yeah, it is quite useful, I think so.
Okay, let me open the last melon. ECU versus FCU. So you anyone in the audience, because you gave your vision, so anyone of the audience giving their vision? I will start. So I learned ECU to ECRB 20 years ago from Scott. And I really haven't done FCU to ECRB. Really, I remember one case, and this patient got a dynamic supination deformity. So that's all my experience about FCU to ECRB. I've done always ECU, with very good results, and I agree that some very flex wrist, the ECU is a wrist flexor. I noticed that. So that's these are my sense. Scott, you can unmute yourself, Scott. You can unmute yourself. No, you cannot.
Yeah, so Paco, we've had the same experience. Unless you can prove to me that the FCU is not spastic, right? If you can somehow prove to me the FCU is truly volitional, not spastic, then we would transfer it. But if it's spastic or we can't figure it out, we won't transfer it. Because I think you're right. It's not just the wrist, it's the forearm. It unbalances the forearm, and they get stuck both in wrist extension and forearm supination. Dan, I can't remember the last time we've transferred an FCU. I can't even recall. Do you remember, Z? I don't remember last time we transferred an FCU.
I don't think we've done it in years. But the other thing I was going to say is the way to judge the ECU. So I'm moving around because people are making noise. The way to test the ECU is to have them bend their fingers. They don't always fire the ECU when they're extending the wrist, but they will fire the ECU when they go to bend their fingers. And so if you just feel right there, you can feel it firing. And I think Praveen is right. It can sublux volarly. And what you'll see is these kids will do this thing where they kind of do this to get wrist extension. And if you bring them into extension, that ECU will sublux dorsally and they can maintain some extension. So, yeah, I just can't remember last time we did an FCU. I think it's a terrible transfer.
Paco, we did just look up
just
our
from
results
what I've seen from other people.
But I will, and maybe Praveen can comment. We just looked up our results of our ECU transfers, and we did find that we had some recurrence if we did nothing to the flexor carpi FCU. If we did nothing to the FCU, there was some recurrence. So our current regimen is actually to do the ECU and do a hyperselective denervation of the FCU. So to get rid of some of that spastic deformity. Because just like Praveen said, it's a double-edged sword. You know, the FCU is spastic, so it's bad, but you need wrist flexion for finger opening. So if you hyperselective denervation, you weaken the FCU, and we hope that'll give us better balance with both opening and closing.
And so I normally associate intramuscular tenotomy of the FCU. You mean also that, or only the nerve?
Either one.
Either one.
Yeah, Paco, you're exactly right. We think you need to do something to the FCU, whether that's a fractional lengthening or hyperselective. Praveen, are you doing anything to your FCU if you transfer your ECU?
Yeah. In most of the patients, we do. And whether we do a fractional lengthening or selective neurotomy, we decide on what is the passive range. If our passive range is coming without much tightness to about 30 degrees, we go for selective neurotomy. If our passive range is not coming till 30 degrees of extension, then we do a fractional lengthening of FCU. So that's how sort of we decide between these two. But we almost maybe on 80% of the times we do something to the FCU as well.
Yeah, I completely agree with that.
Okay, do we stop here? Okay, so thank you very much. Maybe I show the board, the new so the new configuration of the PULM Talks aquí. Yes, you see that the family. What I'm doing. Can you see the? I don't know what I'm doing.
You are
Can you see
sharing
the
your
image?
computer. Yes, we are watching your.
Okay. So just to yeah. Share. Sorry, I don't know what I'm doing. Aquí, I really don't know. Share, Finder. Okay, again. No, I don't know what I'm doing. Share, Finder. Really, I'm lost.
Stop share and then open
Sí.
the file and then put share again.
A ver. I don't know. Aquí. Aquí. Okay. No. Share. Documents. Again, I'm lost. Screens. Finder. PULM board. Okay, now you can see the. Okay, now it's okay, right? So
No,
no?
it's completely it's like blurry.
Caña, ¿qué pasó aquí? So let me try again. Vamos a abrir aquí. Share. Let me go aquí. And now? Can you see now the... No, pues déjame ir aquí. Share. Now?
Yes.
Okay. Finally, I don't know. There is something in my laptop because it's not working as usual. Just to show you, we have organized a director of the PULM for every month. As you can see here, I will not present anyone, but you can see that all of them is people who is entirely dedicated to pediatric hand surgery. Each one will be responsible for finding speakers and topics every month, and that's I only want to animate people to give energy to people to be with us at second Sunday of every month, and that's all. So thank you very much. I don't know if you want to add any other people in the board want to add anything. So next month, we have Takehiko Takagi will present next month, and we have the program already done. Let me see if I can show you. Can you see the program or not?
Yes, it's okay.
Okay, so these are the talks for next month. Have a look, and yes, I take advantage to say you bye-bye and see you next month. Thank you to everybody. Praveen, I enjoyed a lot. Really, I enjoyed a lot. Thank you, Praveen.
Thank you so much. Bye.
Bye-bye.
Bye.
Grande, Andrés.